I'm just going to introduce that symposium, and then we will get into action. So you are in room 241, and the topic is simplifying complex intervention by adopting angiography-based coronary physiology and her healing targeted deaths. I'm Patrick Serrais, and let me introduce the people who are in the panel. You have Andreas Bombach from London. He will act as the moderator. You have Peter Smith, which is going to present and discuss some of the data. Faisal Sharif from Galway. Peter Smith is from Rotterdam. Faisal Sharif from Galway will be also a case presenter. And then you have Joanna also presenting a case. And finally, Gabriel Scanet will be discussing and presenting some data. So if you are here, is to learn a few things, I hope. First, to learn how to apply angio-based physiology to optimize patient selection for PCI. That's really a hot topic. There is many systems, QFR, angiography-based, who potentially could replace the pressure-based system, the use of a guide wire, which is costly, take times, and minimal, but well, sometimes a risk, so that we will learn about that. Then we will discuss a technology which is quite fascinating, the healing targeted deaths, the HT Supreme in short term, on outcome and DAPT duration. And finally, we will learn about how to do the implantation and about the ongoing QFR guided trial, the Pioneer 4, that some of us has the privilege to conduct in Europe, collecting the data and analyzing the data in Galway. That was my introduction. I give the floor to Andreas.
Well, just the usual mention, if you have questions during the session, stand up and go to the microphones. We're on the web, so we need to speak into the microphone so everything is clear. And we have an online chat and a chat master who is looking after the online community. You can also ask questions through the app, and we will try to answer them. That's all I have to say, and now we can properly start.
Yeah, so it's interesting. We will start by what they call interview, okay? And I'm going to ask a question, 3 questions, to Peter Smith. We know each other for many, many years. So, Peter, my first question, let me read the question. Very organized. What is healing targeted deaths, and why can it make a difference?
Thank you, Patrick. And maybe to answer your question, it's best to illustrate that with some slides that we spontaneously have organized for you. Can we have the next slide?
If you want, you can go to the
okay,
lectern.
maybe.
I think the mouse left the podium there, fall off the podium. So the mouse is maybe on the ground, no?
Good.
Yeah. Still alive. Good. Mouse is still alive.
So I will talk about the fundamentals of the HT Supreme Stent. I have no conflict of interest to mention anything about the product or the session. Concerning the HT healing targeted drug-eluting stent, I think there are 3 important components of the stent that are definitely different than other competitors, and which I will touch upon. It's about the drug dose, the pharmacokinetics, and about the EG grafting, the electrografting coating. If you look more closely at the HT Supreme coating structure, you can see it on the right on the picture. It has a biodegradable coating. That's the blue layer, and then we have a electrografted proprietary baseline coating, which has specific characteristics, and then you see the cobalt chromium stent platform, and this electrografted baseline polymer was actually developed to facilitate rapid reindustrialization and inhibit neointimal hyperplasia. And what is it actually, this specific electrografted coating? It's an ultra-thin base layer bounded to the surface of the stent. It acts as a blood-metal barrier, so no interaction between blood and a metal. And it has an excellent surface for biodegradable polymer to adhere. It's what they call a kind of a biological Velcro situation. And here you can see on the electron microscope images the electrografted coating, which is very thin, 200 nanometers. Then the other topics that I'd like to discuss, which is so different on the HT Supreme compared to other stents, like for instance the Xine stent or the Resolute stent, which you can see on the left on the drug release. It has a very short drug release compared to the other drug-eluting stents. Here you can see that the peak of the drug release is about 20 days, where others it extends up to 120 days. You can see on the middle that the arterial concentration, that it has quite high in a very early phase, and then it really goes down to almost zero. And that combined together with this polymer degradation, which is also a little bit different compared to other biodegradable polymer drug-eluting stents, the HT Supreme biodegradable polymer degrades in 2 months, which is shorter compared to for instance, the Synergy stent or for instance the Ultimaster that have both 3 to 4 months, and definitely shorter than the Oceo stent, which is more than 18 months, and of course totally different than the durable polymer stents that we know.
Very good, very good. I think maybe the inventor of that technology is in the room. I don't know if Christophe is here. He's there. That's the inventor. He's French. He's from Paris. Yeah. And he's a brilliant mind, believe me. He could blush, but he's a brilliant mind. So I hope that we will demonstrate more good things with this technology. The second question, Peter, is what is the expected additional clinical benefit from the HT-DAS?
Well, that I can also best illustrate with some slides. Here you can see the in vitro studies that have been done with the HT Supreme stent. On the left you see the Evans blue staining. Evans blue staining is a marker for endothelial cell membrane integrity. And on the right you see VE Catherine staining, which is a marker for endothelial cell integrity and cell contact and cell signaling. And as you can appreciate that compared, for instance, to a kind of a durable polymer stent like the Xines on the bottom, or you see, and also compared to the bare metal stent, you see that the permeability of the HT Supreme stent is quite good, even better than the durable polymer stent. And on the right, you can see the marker for endothelial cell integrity as well, which is also showing that you have quite good endothelial cell integrity. And on the bottom you can also see that compared to the Xine stent, you have a good coverage of all the stents. And that was also observed not only in vitro, but also in humans. And this is a nice study done by the group in China, where they did the OCT study, looking at 1 month OCT after implantation. And you can see and you can appreciate the OCT images, where you can see on red the uncovered stent struts, and on blue the malapposed stent struts. And there you can see that you have in comparison to Xines, a very good strut coverage, and a better strut coverage, and less malposition.
Excellent. So the last question, and then you will have done what you have to do. Yeah? And the last question is, what is the available supporting clinical data and ongoing trials on this technology?
Thank you, Patrick. Yeah, this is a nice overview of the quite extensive study overview. It started, of course, with a kind of CE marking study, the Pioneer 1, that was done in Europe to get E marking in the Netherlands and in Europe, sorry. And then followed by 3 studies done in China, the Pioneer 2 randomized controlled trial, and the Pioneer 2 OPC, and the Pioneer 2 OCT, which I showed already some images of, looking at different endpoints like late lumen loss, target lesion failure, and strut coverage. All have been completed and published. And then we have the pivotal Pioneer 3 trial, 2-to-1 randomization in 1,629 patients, more comers in a global study, looking at TLF at 1 year. And I will show you some more about that. But we also have now this interesting Pioneer 4 study, which we will discuss more later during this session. So let me present to you the Pioneer 3 results. The Pioneer, as mentioned, large study where a comparison was done between HE Supreme and Excience, or the PROMISE stent, looking at a primary endpoint at 1 year, target lesion failure, and a non-inferiority design. And here you see the 1 year results compared to science, very good results of 5.3 versus 5.0, very comparable, and non-inferiority was definitely reached at 1 year between in this study. Looking more at specific safety endpoints, the combination of cardiac death and target vessel myocardial infarction, you see again a very favorable outcome, specifically for the HT Supreme stent, but not reaching statistical significance, and also no differences was observed at the stent thrombosis, but very, very favorable low event rates. Thank you.
Very well done. Thank you. Thank you, Peter. So by now you are all expert on HT Supreme, so enough theory. I think we should go to the practice. Faisal, and Faisal will introduce a case which is HE death implantation in a high-risk bleeding patient.
So thank you very much for the invitation, and glad to be here. My job here is to present a case that we did in Galway University Hospital recently of a patient with high bleeding risk using the technology that is just described, HT Supreme. No conflict of interest for this presentation. So the case is of an 86-year-old patient who has multiple risk factors for coronary artery disease, is hypertensive, previous smoker, dyslipidemia. He's known chronic kidney disease, stage 4, and his GFR values have been around 28 ml per minute per meter square. He's chronic anemia, hemoglobin in the range of 10 to 11 grams per deciliter, normal platelets. He's been investigated currently for prostate cancer, but awaiting investigations, nothing's confirmed yet. So presented in 2022 April with ongoing angina, crescendo in nature, to emergency department. Troponin levels were marginally raised at 39, no significant ECG changes. He was treated as acute coronary syndrome, pro-BNP 450, and pre-test coronary artery disease was 87% based on the criteria that we used just now. So diagnostic angiogram was performed via right radial artery. You can see the calcified right coronary artery with minor atheroma in the proximal and the distal segment, dominant vessel. We did the left, and again, left main is normal, circumflex non-dominant with no significant disease, but there is a significant angiographic stenosis of the proximal LAD, which is diffuse in nature and appears to be more than 20 millimeter to 30 millimeter at least with the TIMI2 flow. The flow was slightly altered in the LAD. As per usual practice, syntax score 1 was 22. So you can do PCI cabbage, We did a syntax score 2, looking at the anatomical and clinical variables, which gives us a 4-year mortality of 22.7 for PCI and 25.8 for coronary artery bypass grafting. Despite the high age, the Euro score was low at 4.3. We had a heart team discussion because of a single vessel disease, higher age. PCI was recommended for this patient, but we were going to do physiology guided. So here we have used the criteria for high bleeding risk, and this patient had 2 major with renal failure and anemia, and 1 minor based on age, and that gives him a risk of bleeding of 11% at 1 year. And we used the other criteria as well, just here for demonstration, but patient was deemed as high bleeding risk patient, and we have to be very careful in terms of how we give antiplatelets to this patient. Patient was enrolled in the Pioneer 4 trial. This is a trial that is after we have done the diagnostic angiogram and patient is suitable for treatment. Patient was treated, randomized into either a QFR guided physiology, guided PCI, or a usual care. The usual care can be an FFR, an IFR, or based on just ECG and troponins. Physicians may decide to go ahead and do it because the patient is an ACS patient and does not need any further physiology. So we performed the QFR, which is the computational dynamics, flow dynamics, and this was positive for LAD at 0.448 with the QFR delta of 0.36. It tells us that the length of the lesion is about 30 millimeter, 29 millimeter to be precise, and 65% diameter stenosis, with the QCA was around 2.6 to 2.5. We performed the same thing for the right, which was negative as expected, 0.93, and circumflex was also negative at 0.95. So here we have angiography and physiology, where we have single vessel disease, which is angiographically significant, also positive based on physiology as per the trial protocol. The proximal, the circumflex and the RCA were both negative. The plan was to go ahead and perform coronary intervention for this LAD calcified lesion. So we start looking at how we're going to treat it. It's severely calcified angiographically. Calcium debulking is necessary. Can we do lithotripsy? Should we do rotational atherectomy? And I think we decided to start with intracoronary imaging, and IVUS was selected for that reason. So here is the first image, CLS guide 3.5. Standard workhorse wire cyan blue. We were unable to get the IVUS catheter across the lesion. Therefore, we decided to put in a 2.5 semi-compliant balloon, which was also, we were unable to cross it. We dilated it at the location to modify the plaque and see if we can get the IVUS through, and this maneuver was also unsuccessful. So at this stage, of course, the next step was to try and do rotational atherectomy. So that's where we get prepared. We continued with the 6 French. You can see the microcatheter that we normally use for exchanging the wires. So we have a cyan blue. We put the microcatheter through down to the distal LAD, and then we put a floppy wire, rota floppy wire. This was not possible because the exchange catheter, which is the and we couldn't get that across either. So we had to just use the floppy wire, which has very little torqueability, and try and get it with the Dynaglide down to the distal LAD. We did a 1.25 burr, and after multiple burring, we managed to cross it and make it easy for us to place stent. Before we did that, we performed the intravascular ultrasound, which showed significant calcification confirmed on IVUS catheter. You can see that the calcium score was at least 3 to 4. There was more than 5 millimeter length of calcium. And there was ostial concentric calcification, and there was a significant calcific nodules, and we did see some fracturing of the calcium on the IVUS as well. So based on that, we started with some dilatation with a small balloon 2.0 and then up to 3.0. We used non-compliant balloons as well. We saw good balloon expansion. We placed 2 overlapping stents. The first one was a 3/0/30 HT Supreme based on the IVUS, and which again led to good expansion. So we were pleased with that. The second one was placed all the way up to the ostium, and we protected the circumflex, which was a non-dominant vessel, and again we performed post-dilatation with a 4O non-compliant balloon to high pressure. So this is the more or less the final result, and it's not mandated in the trial to perform intravascular imaging, but for this case we did perform it because of the amount of calcification, and we saw a very good stent expansion and no malopposition. So there were no further post-dilatation was performed in this case, and we achieved TIMI-3 flow as well. So stent expansion was more than 80% of the minimal stent area. You can see here that we have some eccentricity, but the stent is very well opposed. And here in the corner, you can see at the left main circumflex bifurcation that there was no plaque or stent protrusion into the left main. So nicely placed, and we achieved a good result. We always repeat the QFR. And you know from the trials that it has to be more than 0.91 to make sure that there is long-term better results. And this was 0.95, so optimal physiological results. And as per the protocol of the trial, we're treating patients with single dual antiplatelet treatment for 1 month. And after 1 month, patient stays on a single P2Y12 inhibitor for 11 months. And at 11 months, which is 1 year time, we stop that drug and restart aspirin, and this is based on all the evidence derived from the trials in the past. So if the patient has high-risk bleeding, normally our strategy is to give aspirin and clopidogrel for 3 months, and then after 3 months, single antiplatelet with aspirin. But if the patient is very high risk, we give DAPT for 1 month and then give them a clopidogrel for the rest of the year. So patient is doing very well at this stage. So this is, just to conclude, a new generation balloon expandable biodegradable polymer stents. We aim to promote vascular healing through early drug delivery up to 4 to 6 weeks. This is virtual PCI quantitative flow ratio guided construction of physiological map of all 3 blood vessels. And we also achieve optimal post-PCI physiology, which is recommended. IVUS guided to reduce the amount of contrast, calcium debulking strategy, and stent optimization. And finally, a careful evaluation of patients' thrombotic bleeding profile with the different risk score is mandatory for an adequate therapeutic strategy. Thank you.
Thank you, Faisal. I mean, Professor Sharif of Galway, it was a tricky case, you know, when you start at that age with a creatinine clearance of 28 ml and the prostate and many other things, was very tricky. I think the procedure was beautiful in terms of pre-treating this lesion. The assessment of physiology was also very important. One thing I would like to say, you said the Euro score is low. You have here a famous surgeon from Barcelona, Professor Pomar. He will tell you that 4.3% 30 days mortality is not a low score. You agree with that?
I fully agree.
Okay.
Oh, yeah, okay.
But he was gentle with the surgeon. He said a low score. Okay, I think we have now a question maybe from the audience.
Questions from the audience or questions here to the panel actually discussing the issues around this case. The first one would go to Peter, actually. What is your routine strategy with HBR patients undergoing PCI? So we've seen what's in the trial. What do you normally do? Where are the problems?
Well, first of all, identify your high bleeding risk patients. Radial approach, I think that's a no-brainer. Then I still would go for full revascularization, physiology guided in many cases. I would select a stent which I feel comfortable for in the high bleeding risk patients, looking at evidence on trials and studies. I would then, irrespective of the complexity of the clinical presentation, I would give 1 month DAPT, irrespective of ACS or stable, and irrespective of complexity. But I will drop aspirin, and after 1 month I will continue with a P2Y12 receptor blocker, But that specific choice of whether it should be clopidogrel or more potent P2R12 receptor blocker, that will be decided by the complexity of the procedure. So in this case, this complex case, I probably would go for a potent P2R12 receptor blocker as monotherapy after 1 month.
Okay. So it all depends on the patient. Joanna, how does that influence, how does high bleeding risk influence choice of stent? Does it?
Yeah, I think it does. We have a lot of data now with 1 month anti-DAPT for a lot of the stents that are on the market. But I think, this stent with really good healing properties, which has almost no leaking Evans blue, I think that makes you feel very safe that you won't get any problems even within the first month from your procedure. So I think that this is particularly good technology to cut down on the DAPT use.
And you use that in clinical practice?
Yes, we are participating in the Pioneer 4 trial, so of course we are using the device in that trial, but also outside of it, yeah.
Okay, and then finally, Xavier, we're now switching tack. Was QFR useful in this scenario, and how?
I think it was very useful because remember that the first thing that Faisal and the team did was to assess what was the functional, the ischemic burden in the 3 coronary arteries, and actually they found that there was only 1 artery that had to be treated. As a matter of fact, Faisal might have recalculated the syntax score based on this to know what it was, and obviously now it would be much more in favor of PCI than it was before because it was only 1 vessel to be treated. The second thing is that they used the angiogram, which was already obtained, as a way of very information about ischemia generation by epicardial disease. So there was no need to do additional information. They knew already what they have to do. And finally, they had information in a way co-registered with the image because the functional information was obtained at the same time that you had a silhouette of the angiogram and a reconstruction of the lumen of the angiogram. They knew exactly which will be the target of the PCI. So I found it very useful.
Sjoerd Hofma from the Netherlands has a question. Sjoerd?
Yes, very nice case showing all those aspects. If this patient now needs prostate surgery in 3 months, what would be your advice on, because they don't want to operate on ticagrelor?
Yeah, well, I mean, that's the interesting question. At the moment, for this particular case, the diagnosis was not made, patient was under investigation, but if that becomes the case, then we have to assess the risk versus benefit of the antiplatelets, and unfortunately, I think we may have to switch him back to aspirin for a short time, get his surgery done, and surgery needs to be as minimally possible because he's 86. So I think maybe switching back to aspirin for a short duration and then recommence the stronger antiplatelet post-surgery, that would be the normal clinical practice we do to taking the risk and benefit into account.
It depends also from when after the PCI, of course. I think that if you have to do by accident very quickly after, there are sophisticated way to do. I mean, I have seen people giving cangrelor, yeah, because cangrelor do the same as ticagrelor, but in 5 minutes, and by the time you stop the infusion, the effect disappears. So I've seen people in that kind of situation going from ticagrelor, cangrelor, okay, then stopping the cangrelor at the time of the operation, of course, and in the hours after, and eventually restarting the cangrelor, because if you start to bleed, you can stop the cangrelor immediately. So just testing the bleeding capacity of the patient, I would say. I've seen that also in bypass surgery. I mean, it has been practiced a few times to have the cangrelor. You know, when the surgeon has finished, drain, nothing is coming from the drain, and so you say, okay, let's start the cangrelor for 24 hours, and if nothing bleed in the cangrelor, you go back to the ticagrelor. So I've seen that.
That's
okay.
Excellent point, actually.
Yeah. let's go to the next interview. The interview. I think you have to go to the lectern because you have to show in this spontaneous interview. You have to go behind the lectern. So the first question is QFR reliable as compared with pressure wire physiology? That's a $1,000 question, eh?
Well, thank you, Patrick. Well, to answer that question, I selected one slide, which is probably because your question is taking FFR as a reference. And probably the most reliable source we have so far is this patient-level analysis of two big studies, two of the favorite studies, 1 and 2, where you have here a large number of patients, in total nearly 1,000 vessels, and where you can see the diagnostic yield of QFR. And actually you can see that is quite good, quite acceptable. So you have sensitivity of 84%, specificity of 88%, and you have an 80% positive predictive value and a very high negative predictive value. Now, let's speak quickly about this. Whenever you do in a properly obtained angiogram a QFR and you find that the vessel does not need treatment, like it was in this case with the right coronary artery and the circumflex, the possibilities that that is a true value is very high. If the QFR is telling you that you should treat the vessel, then you have a lower positive predictive value. Now, in most of the cases, the reason for discrepancy between FFR and QFR have to do with the presence of microvascular disease, and we demonstrated this in research that was published. So that explains that, you know, when QFR is telling you that you should treat the stenosis, but you go with an FFR is telling you that you should perhaps not treat the stenosis, is because FFR is telling you that the stenosis is not the problem. There is something else that is there. Now, this may sound like the Achilles heel of QFR, but later perhaps we can elaborate. Under certain circumstances, like aortic stenosis and acute coronary syndromes, it can be a big advantage over FFR.
Very good, very clear. The next question is a little bit more cryptic. Which are the ideal patients for QFR-based physiology?
Well, I think that, you know, the situation we have now is that obviously the mainstream indication for QFR is the same like for FFR, it's setting the indication for PCI. Or if you wish, looking to the half empty bottle, avoiding unneeded interventions, because it has a very high negative predictive value. So you will really be safe on the side of knowing that there is no need to treat when QFR is above 0.80. Multivessel disease, like the case that we just saw from Faisal, is very useful because it really contributes to reclassification of the treatment that you may have. You may convert very quickly from an indication that initially, angiographically speaking, with CABG to perhaps PCI, and in other cases to medical treatment. So from that perspective, we have the functional syntax score, which I will show now a couple of slides. The other aspect that I think that in the non-culprit stenosis of acute coronary syndromes is a very attractive tool. Of course, the great advantage is that you may perform a STEMI in the patient, send the patient to the ward, and retrospectively, so to speak, or later analyze this non-culprit stenosis and decide if you have to bring the patient back to the cath lab to treat it or not. Now, I think that the indication of FFR to guide revascularization of non-culprit stenosis that never reached the recommendations in the clinical practice guidelines, so therefore it is not a big problem. It is currently being challenged by the results of the FLOWER MI and other studies that are consistent regarding perhaps the decision-making in this context. Now, whether QFR can be advantageous in that situation or not is something that we may discuss later, but perhaps there is even, in relation to what I mentioned before of transient microvascular dysfunction, perhaps may have even a superiority over conventional FFR in the acute setting. And finally, planning of PCI, which starts first for deciding if you will be able to improve the functional status of the vessel, or if you have diffuse disease and you will not be able to treat, knowing exactly which segment you should treat, avoid geographic mismatch. Very quickly, this is something that with Patrick and the Syntax 2 team performed some time ago. It was analyzing all the 3 vessel disease patients included in the Syntax 2 study and analyzing the syntax score obtained with angiography as clinical practice guidelines do recommend, and the functional syntax score, which leaves out of the calculation those vessels or those stenosis that are functionally no relevant from this perspective. And you can see that in this particular case, the patient moved from a syntax score of 27 to a functional syntax score of 9. And in terms of planning interventions, this is a good example from our practice of a patient that has a dominant circumflex with 3 stenosis, and you have to decide which is the segment to treat. I mentioned before that QFR provides an immediate, so to speak, co-registration of functional measurements with the anatomy. So you can clearly outline that there are 3 separate steps here that of estimated drop in pressure, of intracoronary pressure. And using this feature that is called residual QFR, you may start figuring out what will be the final result once that you have treated a specific segment. So for example, if you treat these 2 stenosis together, like we did here, then you can really see that the residual QFR is 0.90, indicating that you don't need to treat the distal stenosis. And this will be for your last question.
Yeah, I think that's very practical things, and I know that you're going to show a video. How long does it take? How difficult it is to use, yeah?
Well, this is a video just taken from our practice. I didn't show you the cath lab. There is a patient going on. The images are being transferred to this workstation. This is Ling Wang, one of my fellows, and so what she's doing is just reconstructing the whole thing. Typically, it takes between 3 and 5 minutes, and then of course you may spend the time you wish in trying to analyze, calculate, predict results, etc. But it takes about 3 and 5 minutes.
Very good.
We have a question, actually from the audience. Nick Curzon asks the question, how do you know if you have 1 in 5 positive QFR vessels, which one is the false positive, without wiring all of them and do a pressure wiring?
Well, something that is very interesting is that we have done developments in measuring also the status of the coronary microcirculation, calculated what we call the IMR angio. And actually at EuroPCR, we presented our first study in more than 100 patients with INOCA, compared with thermodilution. And we found that the results are excellent. So it looks like you can infer what is the resistance. Now, one of the important aspects of measuring IMR angio in these patients is not only to know if they have microvascular disease, it's because if you are able to see that IMR angio is very high and you have a QFR that is positive, you should take it with a pinch of salt. It's a very nice way of increasing the positive predictive value. Whenever you have abnormal QFR, an ischemic QFR, and a normal IMR angio, this increases enormously the positive predictive value. So we believe that very soon we will be combining assessment of microcirculation with QFR to improve our assessment of epicardial stenosis.
I have maybe a question, and coming back to your case, you remember that right coronary artery with this very eccentric plaque, we can call plaque, but QFR, which was okay. In this case, it was a perfect treatment. The age is 81, etc. But let's say that the patient is 40. Yeah. What do you do with this eccentric plaque, which has a QFR of 0.90?
I think based on what we have seen so far, we would be conservative for the moment. And if patient is if the young patient comes in, I mean, I think there is if patient has symptoms, based on that, you can repeat the physiology with an invasive wire. But what we're seeing with the current data, I think I would just treat him conservatively, not to do any more.
Gabi, a little bit imaging of this very eccentric lesion in this 40 years patient. You remember the right coronary artery of Faisal?
Well, I mean, I think that, for the time being, the objective of PCI is to relieve flow-limiting stenosis and not to address the biological substrate. Although we are, of course, moving in a new era where biology, I think, will be playing a very important role in knowing how to treat the patients. This is what I feel.
Gabi, you remember, I think 4 years ago, you were doing a live case with a circumflex, very eccentric. You did the FFR at that time, and you say, I don't do that lesion. How is the patient? I said, I will ask you for 4 years.
let me check my records and I will let you know.
Okay. We've got a little quick question from Mika Dorsch, who is on site. In what percentage of patients can you successfully calculate the QFR?
No, that's a very good point. That's a very good point. So you have certain exclusion criteria. If for the time being, we are just now submitting the results in left main, but left main is not an indication. Ostial stenosis is not an indication. And something that is extremely important is, if I may ask you, is how good are your angiograms? I mean, this is something very important because the technique relies heavily in very good angiographic technique, which I'm afraid is not always good in every center because we don't have a culture of obtaining really good angiograms. But there are certain, I think that, this is a technique that is synergic with wire-based physiology. I mean, you should not be thinking that this is going to replace wire-based physiology. The colleague that was asking before, what would you do if you have doubts about that positive QFR thing? I think that what you will do is confirm with a pressure guide while, embarking between that. But it will help you enormously in planning your procedure. And as I say, because it has a very high negative predictive value, it's a very valuable tool, I believe.
But I mean, the point is that if what Patrick's question was that if this man was 40 years old and the QFR is 0.92, I would still be very confident to leave that patient alone. Now, if the QFR was 0.82, then I would certainly think about repeating it with the wire.
I think that 0.82 for a 40-year-old is a positive result. I don't think that, cutoffs are good for, cutoffs are just something that we have to use in trials, but we know that this is a continuum, and it is not the same, ischemic burden in a 40-year-old than in an 85-year-old. So you have to put all these things in context, and that's why we are physicians, not technicians.
Very good, very wise, good answer. Let's thank you, Gabi. Thank you, was very good. So we go to the second case, and that's a practical example of QFR-based PCI in a STEMI patient. Joanna?
Yes, thank you. So indeed, this is a case that we did in UMCG in Groningen. We are participating also in the Pioneer 4 trial, as we said, and this is a patient that presents with a STEMI, actually. 75-year-old lady with diabetes, dyslipidemia, hypertension, so 2 minor high bleeding risk criteria. She has an inferior STEMI with complete AV block. She also has some mild or moderate dysfunction of her kidney function. So this was her initial angiogram. You see that there's very slow flow in the RCA, which is the culprit. And you can see at the same time during the procedure the angio of the left system. And you can see that in the LAD you have over quite a long segment, significant disease, at least 70%. And the whole LAD is actually distally quite fragile. So, of course, we treated her for her STEMI and the culprit lesion. She actually ended up getting also a permanent pacemaker for complete heart block. And then, she has this LAD lesion. Do we have to bring her back for another procedure after 6 weeks or not? And so we actually used the initial angiogram to evaluate the LAD. And this is, so you can appreciate here that we did 2 different projections, trying to avoid the overlap. trying to do the best we can in getting good pictures in this hypotensive and sick patient. And this is the result of the QFR. So during the index STEMI procedure, so you can see that this is a positive QFR with a number of 0.68. You also see that there's the proximal lesion, of course, over the long segment, but there's also some distal disease. You see that if we treat the first segment, the proximal segment will probably, and place around a 35 millimeter stent, will get our QFR post-procedure up to 0.89, which is, I think, a fairly acceptable result in this lady. You can see here a nice correspondence in our measurement in the QFR, and this here, this drop, and then a really small drop in the very distal LAD. So lots of information. I think if this QFR was negative, you could have saved a repeat procedure for an FFR for this patient. So we also did a quantitative flow ratio on the circumflex, and that was osteocircumflex, and that was negative with a QFR of 0.83. And now we brought her back to the lab for a staged procedure. And you can see that the QFR in the LAD at the staged procedure is pretty much the same, 0.67. So it is a reliable result. We could have used the previous angiogram to obtain all the data. We confirmed this because, of course, there's a little bit of controversy. Is this reliable with FFR? And FFR was also 0.68, so consistent. So a strategy for revascularization, pre-dilation, there's a diagonal that bifurcates there, so we did a provisional wire placement in the diagonal, but no plan to stent the diagonal, where we fenestrated and dilated a little bit in the diagonal after placement of a 3.0 by 35 millimeter stent at 14 atmospheres, and we post-dilated proximally with a POT. So this is the QFR post-procedure, and indeed, this is 0.89 as the QFR earlier predicted after successful stent placement. I mean, I think here if we had a nice drug-eluting balloon, which I believe Christophe has also developed, then we could probably maybe be obsessive-compulsive and treat the distal LAD as well, which is smaller and frail. But this was, I think, an acceptable result. We repeated the QFR of the circumflex, and that was 0.88, so still not significant. And yeah, I think we discussed this before. You know, I think QFR is important to plan your procedure. You get a lot of information from it. You know exactly what you'll expect as a result when you place your stent. You have your stent length and your stent diameter when you do it. And if you achieve a good result, and it's a really good feeling when you get a QFR of 0.99 of 1.0, I can tell you at the end of the procedure, you know that your patient will do well because you reduce that TLR rate dramatically when you get a QFR post-procedure that's above 0.91. And this is the data that I think has been shown previously about that. So just essentials to remember. QFR is feasible in non-culprit lesions in STEMI patients. You don't need to wire, you don't need to administer adenosine. I think it would have been impossible to do adenosine in this lady who was having a complete heart block during the initial procedure. You avoid any potential complications in the non-culprit lesion. Ticagrelor monotherapy is also safe, I think, and feasible in STEMI patients, especially in high bleeding risk patients. And this is also partly due to the fact that H2 Supreme stimulates rapid endothelial healing, as we showed in previous slides. So this is again this comparison on the index procedure and the stage procedure QFR, showing you that it is feasible and reliable. Thank you.
Very good, Joanna. On this specificity of the QFR, Javier,
Does it need anything special to do QFR in multivessel disease and in STEMI presentations as compared to a standard assessment with QFR? Different angiograms, different angles. Do you need to do anything differently?
No, not really. Not really. I mean, perhaps, well, I may say that perhaps, you know, I'm thinking aloud. But perhaps if you are performing the angiogram at the time that the patient is in the acute phase of STEMI and the patient is tachycardic, you know, because it has fast rate or whatever, I probably will make the angiograms at 30 rates per second, just to have better appreciation of the speed that the contrast moves down and to measure the TIMI frame count, which is an integral part of the calculation. The other aspect is I will make sure that they give enough nitrates, because in the acute phase of a myocardial infarction you may have vasoconstriction, and this may affect your measurements. But apart from that, Andreas, is not much different.
The only small detail, technical, is that some labs are working now with 7 frames per second, and that's not enough. You have to get classically 12.5 or 15. That's necessary for some of these software on QFR. Yeah.
That is a true limitation in our lab, also for post-processing, right? Everything routine is done with 7.5 frames per second, and we know that the quality of QFR is okay, but not really top. You need 15 frames per second.
I ask, it has the same rule in multi-lesion in the same artery like IFR?
Sure. No, that's it's one of the beauties of it, because in a way, you know, it's theoretically, because of the way that the system is calculated, you have less. You do not have in the reconstruction the crosstalk between stenosis that you may probably notice if you have an FFR measurement. So that from that perspective, theoretically, and I don't think that there are studies that have this compare this in depth. Theoretically, you have a better prediction of what will be the modification of the hemodynamics treating one segment with QFR than, you know, perhaps with FFR, perhaps.
Go maybe for the microphone for the rest of the audience. Yeah.
Thank you. Just my question is that blood pressure or hemodynamics of the patient, whether in shock patient or those who admitted with very high blood pressure, affect the result of a QFR or not?
We simply do not have data. But, you know, the big difference between QFR and an FFR wire is that in QFR, the outlet conditions, or what we call the boundary conditions, are assumed, while in FFR they are real. So if you are telling me of a patient that has a cardiogenic shock, where you may imagine that the left ventricular ejection, end-diastolic left ventricular pressure may be 40, 50, this has an effect on the microcirculation that hopefully will disappear when the patient is better. And that will, at the time of assessing with FFR in cardiogenic shock, that basically will tell you the problem of the patient is not the stenosis. The problem of the patient is what is happening now. So that's basically the way that you have to read a negative result with FFR. QFR will be assuming that the microcirculation of this patient is entirely normal. So if you conduct a study now saying, is QFR a valuable tool to measure FFR, to measure stenosis severity in patients with shocks, and you use FFR, the study will tell you QFR doesn't work. The ROC course will be very bad, because the values are not good. Now, the question is, which of the two techniques is better in predicting what will be the functional severity of that stenosis, one that left ventricular end-diastolic pressure is normal? You understand? So, and this is something that we have to keep in mind. Please forget the old concept that FFR is the gold standard. I mean, that's
That's very good.
Thank you for this nice presentation. I would like to ask about if we suppose this patient is active and he can perform exercise test. Can we perform exercise test for this patient after 4 or 5 weeks? And we just to know that any signs of or symptoms of active ischemia, I mean, there is no need for FFR or QFR. Is the exercise test is enough for this patient for stenting of the LAD?
Yeah,
I don't know
sure.
whether my question is clear or not.
Yeah, I think you have a valid point. I mean, you know, this is a 75-year-old lady that has some comorbidities. Yeah, I suppose you could say that for her, symptoms are most important and not the prognosis. And you could say, well, if her exercise test is good and she is asymptomatic, then I'm not going to do anything. I mean, if she's younger and it's the whole LAD that has significant ischemic burden, then I think I would err on the side of treating. Yeah.
Okay, thank you very much.
Just to be a little bit what the European Society of Cardiology is saying is that in ACS, it is not a 1A, it's not a 2A, it's a 2B. You can do the complete revascularization during the procedure. Now, in STEMI, there is a wonderful paper published in April in the Korean Journal of Circulation. The Koreans are very good researcher. And they have done a Bayesian analysis of all these trials with STEMI and multivessel disease. And there are two conclusions. First, it doesn't matter if you use FFR of angiography, even visual. There is no difference, but there is a clear difference about doing the revascularization or not doing the revascularization. And that's based on 12 studies, yeah? Good. Any more questions? Because we are getting slowly to the end. I'm not so, yeah?
No more questions from
No
me.
more questions. You see, when you say that, somebody is coming.
About QFR. So we know that physiology is recommended, FFR is recommended, but the penetrance in the real world is low and has remained low during time. Do you think that QFR will increase the penetrance of physiology guidance in the real world practice?
I'm very curious to know. I mean, you know, I trained with Patrick, and in the 90s, you know, we were working with QCA, thinking that QCA will be something that will change our life, assessment of coronary stenosis. Now, every single angiographic machine that you have around the world has a QCA package, and who is using QCA in your decisions, you know? So I'm curious to know. I mean, it's the big question mark. Hopefully, it will help. I think the circumstances are entirely different. In 1992, we were too busy saving lives as to worry about if it was severe or not. And nowadays, we are much more aware than, you know, setting the indication, avoiding unneeded interventions, planning well the indications is much more important. So probably, you know, this is a much better scenario for people to adopt these techniques, hopefully.
Yeah, I think that NICE in UK is watching us very carefully and watching this type of trial because, you know, NICE in 2017 recommended CTA and FFR-CT as a first line of diagnostics test. And they may do something similar, but they are watching. They need clinical data. So I have to summarize the talk. I mean, to learn how to apply angio-based physiology to optimize patient selection for PCI. I think that you had a beautiful analysis by Gabriel Scanet, and clearly you have seen the power of that technology. And indeed, you can defer some vessel, which is important. We are not there to put metal in every patient. That's the patient of Faisal with these eccentric lesion in an elderly patient. There was no reason to put metal at that age in that patient for this lesion, and the same was true for the lesion in that vessel. The result after that was perfect. With 95, you know that the vessel-oriented composite endpoint will be very low, around 3.2, 3.5. I like that slide because it's not easy to answer. I'm not going to describe again, but I think you can put that in your frontal lobe, you know, or in your retina, because that's really how to use it. It was not an easy question, but you respond that beautifully. and he shows us how you can transfer the syntax core anatomic in a functional syntax core and somewhat downgrade that three-vessel disease, which we know from the syntax 2 is beneficial. I love also these slides. Keep that slide. These slides are available, how to calculate without a planner in a very simple way that the third lesion should not have been treated, because if you treat the first two, you get already a QFR of 0.9. What is EG coating? We should not forget that this is a symposium of Synomet. I mean, they were very generous to let us introduce the QFR, so powerful. You have all seen. If you want to know more, you go to Christoph. He will explain that in much more detail, but it is a beautiful technology, because many years ago, I called him on Christmas Day, I think, to say, what is this coating and why you call that electrografting? And he did something which is not easy. He connected the polymer with the metal by a covalent binding. And yesterday, again, he was telling me how much energy in kilojoule you have to break these things. So it's a very robust technology, beautifully illustrated and explained by Peter Smith. Again and again, I mean, you should realize that Dr. Sun, a PhD of Scrip in San Diego, has the idea that the drug should be released quickly, because you have to give the chance to the endothelium to come back. You want to inhibit the restenosis process, but you want to have the endothelium very quickly. That's the reason why the drug release is fast, to get this good endothelium, and we have to rely on that. And we will need long-term data, because, you know, permeability of the endothelium in the early phase may have some impact on late neurostenosis. I'm finishing, I guess, on this slide. This is a trial that just started. We have the trial manager in the room. It's amazing that so quickly we get this 140 patients, and it's a slide dating from a few days. I think by now it's 160 or 62. And you see, I'm a little bit chauvinist being Belgium. I see a lot of Belgian people there, but I have been also working 40 years in the Netherlands, and I'm not in Highlands, so there is some conflict of interest here. Yeah, I think it's my last slide, and I thank this wonderful panel who has entertained us on the scientific, very important point. Thank you.